Shall we start, Himanshu?
Yes, ma'am.
A very good evening to all of you. I welcome you all today for the very important fifth episode of Counselor Empowerment Program. And we have some very interesting talks lined up with you. This is a presidential program and I'm the national coordinator. Dr. Rajvi.
Yeah, so we have Dr. Piki Sharma, who is actually, Piki Saxena, who is doing all the background work for this empowerment program, counselors from the base of an infertility clinic. Because according to me, infertility is an emotional disorder because the symptoms are emotional. And whatever we do, treatment comes much later. So the counselors play a very crucial role in helping these patients cope with their emotions. And I really appreciate Dr. Piki to take this up, and she's been consistently working on this empowerment program for the counselors. So without much ado, we will start the program. Over to you, Dr. Piki, the coordinator of this program.
Yeah, so I think Dr. Pankaj Talwar, he's the president, and it is the presidential initiative that this counselor empowerment program has been started. Actually, with the 2021 ART Act, it is mandatory that each and every level 2 clinic should have a counselor. But there's a dearth of counselors. Till now, we have not been having any counselor, any trained counselor in most of the ART clinics. So this endeavor is very, very important. The infertile couples, they are already suffering from a lot of financial, mental, physical agony, and they have a long journey. So in this, there are lots of ups and downs. So telling them what is to be done, how the procedure is going to be planned, and hand holding during the difficult times, informing them, taking the medical legal point of view also into action, getting the full forms and everything, the financial part into account. And, having a counselor is going to, help them for treatment adherence. Otherwise, they are going from one clinic to another. So if you want to retain the patient in your clinic, it is very important that you have a very good counselor with you. So this endeavor is, sirs, it's very close to Dr. Pankaj Talwar's heart. And he has started this initiative so that we can have some trained counselors. And this is Dr. Shweta Mittal Gupta. I think madam needs no introduction. She's a very dynamic co-director and unit head, Center of IVF and Human Reproduction at Sir Gangaram Hospital. And she is the General Secretary of our IFS. Dr. Geeta Khanna ma'am, she looks so beautiful. Ma'am is the scientific director, and she heads the ART unit, high-risk pregnancy, endoscopic surgery unit, and is currently the vice president of IFS UP chapter 2022 to 24. She is the mentor of our counselor empowerment program. And we have another very, very dynamic and very sought after clinician, Dr. Poonam Nair. Ma'am is also, she's a clinical psychologist. Ma'am is also the convener of SIG, Special Interest Group of Counseling Psychological Support. And she is very passionate and keen teacher, researcher. And recently her guidelines have been released by her in the ESHRE conference. So that is very, very prestigious to us. In this program, we have nearly 400 members. And our first program was launched on the 28th of May. And these were the important people. The salient feature of this program is that we have the clinicians, we have the psychologists, and we have a very capable embryologist, the only single embryologist, and Astha, who is a AI engineer. So we have a collaboration of this different mixed population so that we can all put our minds together. We've been holding so many workshops and these counselor empowerment programs in which we have been having dialogues between two counselors, case studies, role plays. So all different types of things to capture the emotions and the feelings of the patient and how to support them. So this was our first program, which was conducted on the 28th of May, 6 to 7 p.m. The second program was done on 21st of June, 2024. The third program on 16th of July. Every time we are taking a special, fixed, small, focused group discussion so that each and every point is covered in the communications. This was our fourth program, which was done on 12th of August. This was also a very interesting program. And today we have the fifth episode. And in this, we are going to focus on the red flags. You know, when the patient is coming to us, talking to us, we can identify, we have certain red flag features, clinical features, emotional stressors, which should enable the counselor, because all of them are not clinical psychologists. So in these cases, these patients need special care and they need to be transferred or referred to a certified counselor. Then we are having Dr. Raj, regarding this, Dr. Poonam Nair and Dr. Poonam Kashyap, both counselors, are going to take up this topic as a dialogue or a case study. And then we have Dr. Rajvi Mehta. She's a renowned embryologist and she's going to talk about the important role of the embryologist and how the embryologist and the counselor and the clinician have to be in sync in giving the prognosis to the patient. They all need to speak the same language, discuss amongst themselves, and then communicate. So all those embryologist point of view things will be talked about by Dr. Rajvi. And then for the first time, we will be discussing the role of counseling in third-party reproduction. That will be taken up by our own Dr. Reenu Tanwar, who is the in charge of ART services and director professor in Maulana Azad Medical College. And this is the core team of members. We have 6 teams. And as I said, we have a mixture of clinicians and the blue ones are the counselors. So these are the people who have been working on focused checklist of the counselor empowerment program. So, and we are trying to develop a ready reckoner for the counselors so that each and every IFS, the clinics in which the IFS is, the clinicians or the counselors are member of IFS, they are all going to get this ready reckoner, which they can keep on the table and see and get guidance on how to go about counseling. These are the important, on the left side are the important points, the checklist that the counselor should be knowing and should cover all the points during counseling. And Astha Puri is our AI expert, and she has developed this beautiful website for the support group for infertile couples. So I thank you all very much. And I think we have Dr. Rajvi to now start her talk. Dr. Rajvi, as I said, is the convener of IFS, SIG, Holistic Medicine also, and she's a renowned embryologist. She will be talking on this.
So, thank you, Dr. Saxena, Dr. Picky Saxena, for elaborating on all the work that the Counselor Empowerment Program is doing. And like I said at the start, the counselors play a very, very crucial role in this whole field of ART because the pain that the patients feel is not physical in most cases, maybe say endometriosis. The pain is emotional, and we need to address the symptoms of a problem first before going to the root cause. And this is something which is often missed out, and I'm glad that we're taking this initiative. So I'm going to be very specific and talk about the role of an embryologist in counseling. First and foremost, does an embryologist have a role? And if so, what is the role? So let's look at the timeline of an IVF program. So first, and I'm not going to talk about the diagnosis and planning stages, but actual ART program. So you have about 10 to 12 days of stimulation wherein the patient comes for the injections, is monitored, and maybe takes the injections at home. Then comes this crucial, very critical 5 days where we create embryos in the laboratory, and then we hope they develop into blastocysts, or what embryos are called when they grow to day 5, and lead to a pregnancy. Now it appears like it's a 5-day job, but I do believe that because whatever happens in this 5 days is going to reflect in the outcome of the program. And therefore, it is very crucial. And then the 15 days wait for the pregnancy test, which I think is a killer for the couples, for the all the people involved. And then we do know that the outcome is very much dependent on the lab, as you know, what exactly has happened. Now, if we talk about, and I'm going to be focusing on these 5 days. Now, what exactly does an embryologist do for those who are not very familiar? Basically, we are trying to mimic the role of the uterus and the fallopian tubes and try to create an environment for the gametes, the eggs and the sperms, to fertilize and create embryos. And in all practicality, it starts with, you know, looking for eggs in the follicular fluids or fluids that we are aspirating after the patient has been given hormonal stimulation. And then after getting the egg, we try to bring about a fusion between the egg and sperm by just making them live together or by injecting a single sperm into the egg. Then we nurture these embryos to go to day 5 to blastocyst. And then we select the right one. And remember, selection is always a difficult process because they're taking a decision. And then we cryopreserve them or preserve them for a month, 2 months or longer. And then we do the embryo transfer. Sounds very simple. And why would that create any kind of an issue with the patient? The fact is that in these 5 days, there are umpteen questions that a patient would have. You know, while they are giving the hormones, you may get 10, 12, 14, 15, 20 follicles. The question is, did we get eggs from all the follicles? Then was the semen sample good? Or if they have done a testicular aspiration, did we get sperms? And then did all the eggs fertilize? Did all the embryos develop to day 2, day 3? Are they growing? And will they survive cryopreservation? Will they implant? Will they lead to a pregnancy? And there are lots of ifs and buts that happen. Because what is the reality is that it's not simple that you've got the eggs, you've got the sperms, you're going to get embryos, and you're going to get a pregnancy. This doesn't seem to happen all the time. And when the results are not 100%, there is stress. So let's look at the real situation. And what are the outcomes at every stage? So when you aspirate the follicles, you get about 80%, and this is average data from embryologists across the world. So it's not somebody of any specific clinic. So only about 80% oocytes are retrieved from follicles. The fertilization rate is expected to be around 90%. We have about 95% of these fertilized eggs become embryos, and about 45 to 70% become embryos on day 3. And out of that, only 40 to 60% become blastocysts. So if we have started with, say, 10 eggs to start with, we may land up with only 4 to 6 blastocysts. And then out of that 4 to 6, maybe 35, 45% may actually implant and give live birth. And when we are cryopreserving them for later use, only about 80% to survive. So the fact remains that we never get 100% results. In most cases, each of these outcomes can never be 100%. So when the things are not sure, it always brings with it certain level of anxiety and certain level of stress because you do not know what is going to happen. And what does it lead? And the question is, why don't we get it? What is lacking? The first is the quality of the gametes. The couples are infertile. It's not that we are not able to retrieve the eggs or sperms, but they are infertile. There are some problems. So we do be a questionable quality of gametes. It's the skill of all the personnel involved because you are handling these, and if you're not well trained, not well skilled, not in the right state of mind, you could land up damaging them. Second thing is the quality of the laboratory. Like I said, we are trying to create an environment similar to the fallopian tube and uterus, and it's not easy mimicking nature. We may try our best, but nature is far ahead of us. So that environment has to be created. And the fact remains that there are about 140 plus variables which can affect embryo development. So even if you're very, very critical, very cautious, very precision-minded, despite that, when there are so many variables, you do not know which one decides not to behave. And that is the reason we don't get the outcomes. So where does the embryologist come into picture? Now, why does counseling need to be done at this stage? Because, you know, when a patient walks in, they are looking at a final outcome. But if they are updated at every stage, they are more objective and more realistic. Because otherwise they come, they either look a pregnancy rate of 50%, 60%. They don't see every stage, because for me, for a patient, the pregnancy is 0 or 100%. It is not 60%. You don't give them 60% of a baby. So either they get or they don't get. The statistics are for a larger situation, but for an individual, it's either 0 or 100. Then supposing things don't work, then the patient can get into a state of blaming their own selves. Oh, my eggs were not good, so that's the reason, that's a problem. Or blame the lab. Oh, they didn't do the procedure well. There was something lacking. I saw the embryologist walking out for some time. Oh, the doctor was talking on the phone. You don't know what is going in the patient's mind. So if they are updated at every stage, then all their doubts lessen. Also, we need to be careful that we don't raise their hopes too much. But at the same time, it's a fine balance. You can't create a negative frame of mind. So whether you say 60% success or 40% failure, it's how we project. And that fine balance is very crucial. We're sort of preparing them for the outcome. And I'm saying the outcome could be anything. And, they can be very vulnerable in this every day. Because when there is uncertainty, there is anxiety. When you're waiting, that anxiety can lead to problems, especially if you're on the threshold of an emotional disturbance, what we refer to as red flags. So we have to ensure that their frame of mind is just optimal. And that's the reason these crucial 5 days, what I called counseling, is important. Now, are embryologists, can they be counselors? I think the embryologists are not really trained to be counselors, because the counselor, embryologists are technical people. They are working with their hands, with their knowledge on biology, but they are important because for the patient, these are the people who have handled their gametes, who are handling their embryos. And for them, the lab is actually the first home. And here I would like to narrate an example. This was one of the first cases of way back in time in the late 1980s, where the patient would lie down for 3 to 4 hours after an embryo transfer. And we had a lab with a glass door, and the patient would be lying down there. So we finished our lab work, got out, and just conversing, casual conversation with the patient. And the patient got a camera out and started taking photographs of the incubator. So I was a little surprised. And he says, no, I want to show the photographs of my child to my child of his or her first home. And that was a shocker for me, because they saw the incubator as the home of first residence of the child. And what was more concerned was that while we were assessing the embryos, I was new. This was one of the first pregnancies after me getting in. And I was told these embryos are average looking, but that's the best we have, so we transfer. And even today, I think even the best embryologists in the world cannot 100% predict which embryo is going to lead to a pregnancy and which is not. So I was, very disturbed. I said the embryos were not good. How disappointed would they be? However, I kept quiet because it was not my place to talk. And, we've transferred it and we hope. And the patient actually conceived. And I realized that the emotions of the patients may in some way, there is no direct evidence, but then we do talk of psycho-immunoendocrinology. So I do believe that there may be some interactions. So the embryologist can become a very strong communicator with the patients. So for the patients, they're talking and hearing from the people who have handled it. And that's, first-hand information always has much more value than something which is communicated. And also the people who have worked with will have different emotions than somebody who is objectively transferring the information. So I think the embryologists can be good counselors or good communicators. I wouldn't say they're counseling, they're stating facts. Now, what are the embryologists? Now, for the patients, it boosts their morale. If somebody else is saying, yeah, it's good, but here there is somebody who is actually handled. Like you go in restaurants and then they put a board, the owner of the restaurant eats here. So it gives you confidence, like, yes, the quality must be good because they're eating here. Then it's a first-hand report, like I said, and I just gave you examples that they're talking to the caretaker of their embryos, which they see as fetuses or babies. So when they're talking to a caretaker, that gives a totally different confidence level to the patient. On the other hand, there is also for the embryologist as an advantage, because otherwise they're working behind the scene, and backstage artists often feel neglected because they put a lot of work in, but they're never so-called recognized by the people they're working for or the patient. So it does move the morale of the embryologist. I mean, anybody gets recognition and appreciation is happy, and if they're happy, they're working well. It also enhances a great responsible behavior, because when you're working behind the scenes, they are just eggs and embryos and sperms. But when you're interacting with the patient, you realize the psychology of the patient. You come to know, oh, this patient is actually sold off all their property and come for this treatment. The responsibility becomes tremendous, because for an uncertain future, they are destroying or maybe the present. So you get much more committed to the work. There can be no casualness. And I must tell you, when I talked to that first patient, it left a tremendous impact on me that I cannot lose a single egg, because who knows if that egg could lead to an embryo which could have implanted. So you become very, very careful, cautious, focused, and involved in your work. And that makes a big difference. And for the ART clinic also, it's a big team spirit, because everybody's working together, not for somebody. Everybody is working for the common goal, that's the patient. Now, if we go ahead, and what is the disadvantage? I mean, is it all a win-win? Definitely not. Because like I said earlier, embryologists are not trained to communicate like a clinician or a counselor is. So they may tend to give over information. You can start using a lot of scientific jargon. There's a blastocyst, there is inner cell mass, there's trophectoderm. Patient picks up words and may not understand anything. And they may pick up this word and Google it and maybe come to their own story depending on the state of the mind. And that can diminish the morale of the patient or, bring harm. Secondly, if the embryologist, because see, when you're working as a team, everybody doesn't have the same decision. We come to a team decision. So there are 3 embryos. Maybe you're discussing with fellow embryologists, maybe you're discussing with a clinician, what is the best thing to do in this case? And then you come to a cumulative decision. But there could be a situation where it is not 100% what you have decided. And that happens in teamwork, and you never know what is right decision. It's always in hindsight. But in this case, if the decision has not gone in your favor, or something has happened, you could vent out that frustration unknowingly, express something. That these things, oh, in my case, I did the embryos well. I did the work well. Why does not implant it? Maybe something to do with the transfer. Now, these can create a lot of apprehensions in the patient, and one has to be very concerned and how much to talk, when to talk. So I do believe that embryologists can be great communicators. It would be a great benefit to the patient, but they need to understand and learn a lot. For earlier days, we interacted a lot with the patient, so it came to us by just shadowing your seniors. But later, today, when they're mainly doing, like I would say, backstage artist, lab, without much interaction with people, it can become a dangerous thing also. So first thing is an embryologist needs training in communication, and such training cannot just come by teaching or by lectures. This is an experience which you learn on, during the work process. So you just shadow people, see how they're talking, understand, and you learn. Or you have a nice combination of an embryologist with a counselor. Both together, the embryologist provides the fact, the confidence, and all that I talked about, while the counselor makes sure that the right amount of information and to identify any expressions of the patient when you're expressing your information. So I think that is something where we can make the best of the professions. So when it comes to embryology and the ART lab, it's a balance between the objective information that you give. You can't give a lot of objective information. I mean, if I start talking the science of it, maybe there may be one odd patient who may be interested. The others may get lost into the jargon and think the whole process is so complicated. What if something has gone wrong? What will happen to my baby in future? So we have to be very careful and also understand the emotional frailties of that individual. When the person, as I said earlier, has a lot of stress because of the uncertainties. And when one is under stress, you are frail. When things are fine, you're strong. So you don't know what is their state then. And therefore, that I think a blend of an embryologist with a counselor can do wonders to the psyche of the patient and the couple. So now for tips to embryologists, if they're going to talk themselves or in the presence of a counselor, it's how much to talk, what to talk, when to talk. Counselors have learned to listen whilst we are going to talk. So how to balance talking and listening? And because I may be talking so much, but what exactly have I conveyed? What has been heard? What has been understood? So that has to be understood by the embryologist. It is like talking to an audience, connecting with them, or memorizing something and just narrating it out where there's no connect with the patient. So what to talk? I think the first thing is just be very objective and factual. We have got 15 oocytes. We have had 14 eggs which are fertilized or 12 eggs which are fertilized. 13 do not show fertilization. We do not know whether they have not fertilized because they could have undergone syngamy. We may have missed it. So just now 12 are fertilized. We have so many embryos. What about the others? We do not know. Sometimes embryos grow slowly. So 3 are doing, because we have to be very careful. If we say slowly, they will sort of go far ahead and say, oh, if a child is born, will the child be a slow learner? So we have to be very, very cautious. So many have grown. And we should not give any judgment on the embryos. Because if we say, oh, they will implant, we don't know. So why do we want to, talk superlative or adjectives? We shouldn't. And we should show a positive side of the percentages. Like I said, for the patient, it's 0 or 100. But still, there are percentages from the larger data. And, you can say the same information as a 40% failure rate or 60% success rate. It means the same. But depending on the psychology of the patient, it is how you present. And I think stories, narrations help. So, oh, yes, we had another patient with a similar kind of a picture. And yes, they conceived in the first cycle or second cycle, or, even if 3 embryos develop, they did get pregnant. So all it requires is 1 embryo to give a pregnancy. Even if you have 3 out of 15, yes, 1 can develop. So, just being narrating this. So we are not saying what are the chances, probabilities, but we are saying it is possible. So the next is what not to talk. That's equally important. So we should not discuss the data or results of any fellow patient. Remember, in the clinic, the patients are sitting together and they are surely sharing information. And that's where, supposing, if you talk, oh, but we didn't get embryos in your case, but we got it from the other patient, that's disaster. Because then they will start discussing with the other patient. And then, if you say didn't get embryos and maybe something grew afterwards and you've transferred it, we are narrating in between those 5 days, they will start doubting. So I repeat, no judgments on the quality, just facts. 3, 4 cell embryos, 8, 6 cell embryos, that's all. And any discussion that has been had with the team should not be revealed at all. No views or opinions on any team members. That's very crucial. We are working together, but it's not that even if 5 people work together, you will have different days where you're getting along, not, and even any minor errors that could have taken place in the laboratory. It depends what is the thing. So if you're talking facts, there's no problem. You don't have to overspeak and no technical details or casual comments. Mind you, the patient is looking at your expressions. They are looking at how you are behaving. And if we casually just walk out, they will start thinking, oh, they didn't give importance to my patient. Maybe your work has been done, but they're observing you all the time. So I think we have to be very careful in our demeanor and in our expression and in our comments. So finally, an embryologist can counsel if they have developed the communication skills, or they can work together with a counselor. And I think the teaming would make a difference is my thing. Now, if I say that, what does literature say? Does it really help? And there's interestingly one paper published long ago where they had an embryologist counseling during the ART procedure. So they had a study and control group. The study group had embryologists who counseled the patient, and the control where the embryologist did not counsel patient. And they found that the anxiety was reduced in the study group in 10 different scales that were used for various aspects of the emotional state of the couple, and it was beneficial. So it's not, maybe it's the counseling, maybe it's the embryologist counseling. Maybe a study can be done where you have an embryologist counselor or both together, But the fact remains that they're using an embryologist as a counselor. And in this particular control group, they had a clinician on the other side. So I'm sure the information communicated was the same, because embryologist would communicate the information to the clinician, and the clinician will counsel. But if the embryologist is a good communicator, then it did help in this scale. So my hypothesis that, the people who are handling the gametes, the caretakers, if they talk to the patients, it does reduce their anxiety. So with this, I thank you, and I hope I've shed a light on a different perspective of counseling and the approach that can be taken to make life of the patients a little more easier in this stressful treatment. So thank you. That's it for me. So.
Thank you, Dr. Rajvi. That was a very insightful, very nice, different type of talk. And we had your perspective, which is very, very important. And I think it has to be a sync between the clinician, the counselor, and the embryologist. And when they hear directly from the embryologist, they get a different type of more confidence, because you are the people who are handling, and each ovum and each embryo is very precious. It's going to be their baby, a new individual. So we need to be very careful what words we are using, how we are prognosticating, and give only objective data to them, and not be very emotional, and also keep the patient's psychology, her emotions in mind. So thank you very much for this beautiful talk. And Dr. Shweta Mittal has sent her small message. So I would request Himanshu to play it before we hear from Dr. Renu Tanwar, a very interesting and important new aspect on counseling for third party.
Good evening, everyone. I welcome you all to yet another interesting program of Counselor Empowerment Program. I'm Dr. Shweta Mittal, General Secretary of Indian Fertility Society. I just wanted to give a small overview of our society that we started with in our new term with around 4,283 members, and now we are over 4,600 members. This is our central team with office bearers, co-opted members, and national advisors. We have 29 chapters, and these are the different chapter secretaries, and we are very proud to say that all the chapters are actively involved in ardent academic work. Now, I invite every one of you who are attending the program today to become an IFS member. It is very, very simple. You can scan the barcode, and it roughly takes about 5 to 6 minutes to become the member. There are many programs which the Central Secretariat is running, like the Genius Junction, the Intelligent Empowerment Program. We have the Youth Empowerment Program, Counselor Empowerment Program, what we are going to hear today, Nurses Empowerment Program, and Self-Empowerment Program. Last is that don't miss the golden opportunity to register and to submit your abstract in the forthcoming Fertivision 2024, which is to be held in Ahmedabad on 6th, 7th, and 8th December. And the last date, which we are very proudly now extended to for early bird registration, is 2nd of October. So don't miss the opportunity, be a part of this program. And very interesting, since this is the CEP program, we have a dedicated workshop which are for ART counselors and support. And I'm hoping that all of you who are listening to the program today would come and join and be a part of this workshop. So I hope to meet you all in Fertivision, and thank you so much for your attention.
So we invite you all for this important counselor empowerment program, the workshop, which is going to be held in the Fertivision under the able guidance of Dr. Poonam Nair ma'am. And Dr. Renu, Dr. Poonam Nair is there. So can we have her session first?
Okay, no issues. No issues.
Okay. So, Dr. Poonam, ma'am, are you there? Please put on your video, ma'am. Yes, I can see ma'am there. Ma'am, Poonam, if Dr. Nair is not ready, then we can have Dr. Renu's session only. You messaged me, so I thought we can have.
Ma'am, Renu ma'am can do first.
I think Dr. Renu, ma'am has joined, but I think there is some problem.
Some network issue, ma'am.
Network issue is there. So,
No, hello, I'm here. Hello.
Achha,
I'm
ma'am,
here.
please.
Okay.
We were waiting.
If you want to sit, you can listen. Yeah. Okay.
And we have invited all the counselors to join your counselor workshop, which you will be conducting in the FER division.
Yeah, all these counselors only are helping me and
Yes.
supporting me right through. So we'll have a, I'm really happy with your initiative and the way you have launched it, spearheaded, mobilized the groups. It's really a very wonderful.
The teamwork, ma'am, and under
Yeah.
your Dr.
Yeah.
Gita.
Teamwork and it's the enthusiasm and speaks about your intelligence a lot, your capabilities.
Thank you,
It's a
ma'am.
huge respect for your
Thank you.
profession. Yeah. So we will be talking about red flag indicators. And Poonam, can you project my
Yes, ma'am.
slides?
Yes,
She's
yes.
having,
Ma'am, can we see you on the video? If you can put on your video, it will be great.
yeah. Hello. Yeah.
That's great.
Fine.
Good to have you.
So we are talking about red flag indicators, and in this process, this is something. Just I'm shifting room because they are starting this insecticide. Oh, sorry. So in this red flag indicators, we are, this is very important because we are in the field of health psychology and we don't immediately are dealing with psychiatric patients where, you don't need any special indicators. They are already there. So we are just, I will be talking about things which are meaningful to the clinician and also hopefully to the counselors. मेरे को pin याद नहीं है. Just a minute. I'll, one moment. एक मिनट. ये है 1307. ठीक है. Now this is based on, actually we have from the IFS side we have got two developments. One is this book on counseling, which we have tried to compile whatever evidence-based knowledge there is on infertility counseling as well as the consensus guideline. It is available. The Intas Farmi is very kind. They have published it for us free of cost. It's available. And, we have been distributing it in various workshops, in webinars. So if anybody is interested, they can contact and we'll see how to arrange to give it to them. Now, we are talking about indicators. There's the diagnostic indicators, which are very relevant for the clinician. Then there are scores on the screening tools and behavioral indicators. Next. So when we are talking about diagnostic and clinical indicators, these are again on the basis of research. And there are specific clinical situations. Once the healthcare team sees this clinical condition, they are alert on the fact that this is a person who needs to be explored more thoroughly in terms of their inner turmoil, experiences, and distress. And it's not just a routine case. So first is previous failed treatment cycle, miscarriage, abortion. Then we have a case of ovarian insufficiency, male factor infertility, male sexual dysfunction, third party reproduction, requiring donor gametes, and history of psychiatric illness in the woman or man. So the moment any of these conditions are there, one has to be alert for significant psychiatric distress. Now, previous failed treatment is, one is in miscarriage or abortion. There is a baby which existed and it is lost. It's a tangible loss. People can understand it. But then when we are talking about IVF, it's like a period. The pregnancy never took place. So there is an intangible loss of a baby who never came, which is more difficult to express, more difficult for others to understand. Next. Now, the other condition is this primary ovarian insufficiency, which is a very bad news for the couple. It's life-altering, emotionally charged diagnosis. And where it implies that the couple can never have their own biological child. When they're married, it's supposed to be their child together, but they realize now there has to be a third person involved. Next, Poonam. Now here, whenever there is a case with this diagnosis of POI, then along with the physical health complications, which the clinician is extremely well aware of, the emotional health has to be addressed also, because there's a feeling of menopause has set in and aging. And then there is additional stigma of infertility, of not being able to conceive unaided, and emotion of anger, depression, anxiety, and they have no, they don't have a choice anymore. Then there's a lot of physical concerns of bone density, cardiovascular risk, and so on. So all this affects the self-esteem and relationship, and especially the intimate relations. Next. Now, this is a case which we had actually encountered in one of the IVF centers where, Poonam, can we read the case? Poonam?
Yes, ma'am. Yes, ma'am.
Can you read the case?
Yes, ma'am. So it's a case related to failed treatment cycles. Mr. K, 34 years, and Mrs. K, 29 years, had 2 failed cycles in some center. Both were well-educated, PhD, and had stable, good jobs. Mr. K had Mrs. K had an AMH of 0.4. She gave history of sleepless nights, nightmares of lost child, post-traumatic stress, excessive anxiety, doubts about embryos being misplaced in previous centers. She did not inform her about grade, number of embryos formed, and she was anxious about her embryos lying around and getting lost, which manifested in nightmares. This IVF cycle, she had 1 embryo of average quality and was advised by the clinician to go for a donor. However, she refused and very categorically wanted her own child, not someone else.
So this is typically from a clinician point of view, you would immediately start planning for her next cycle, seeing her history, but you look at the subjectivity which is undergoing with this level of very high stress and unresolved emotional complexes playing deep within her. It is likely to sabotage the further treatment. So we had to manage her at an individual level and clarify her doubts. And, what we are coming to is this grief reaction.
Yes,
when
ma'am.
you want something, you lose, you are unable to have it. We see the sadness in the couple, but do we realize that there are so many emotions? Next slide, Poonam.
Yes, ma'am.
Poonam, can you do the next slide?
Ma'am,
So
I've
can
done.
you see the reactions? There is not just one emotion. There's shock, denial, anger, depression, dialogue and bargaining before being able to accept. So this is an academic drawing. In reality, it's all tangled up. Sometimes angry, sometimes depressed, sometimes accepting, sometimes in shock. So this requires a very careful handling. Next. Next slide. So there are many shades of emotion during grief, and all this has to be sorted out before she is actually psychologically ready for the treatment. It is a red flag indicator. Many of us see patients who are coming from different centers with failed cycles, and we immediately handle the clinical part, overlook this. But this is very important. Later on, with a failed cycle, she may have a breakdown. She may put you in a legal trouble. She may become aggressive. She can react in any way. Either way, it will be bad for the team and the patient. Next. So the other factor that is very important to keep in mind is male infertility, in which we are talking about male factor infertility as well as male sexual dysfunction. Whenever we have this diagnosis, again, it is a red flag indicator, because with men, the male factor infertility or dysfunction is very stigmatizing for men, much more so than
For a woman.
for women. It is a humiliating and emasculating to men. It has profound adverse impact on perception of masculinity. They think I'm not a man enough or what, because with men, they conflate infertility, virility, and sexual potency, leading, to perceived personal inadequacy. And there's a cultural stereotype of masculinity. That is, you cannot be vulnerable. You have to be tough and in emotional control, and you minimize the need for assistance from others. So this whole concept gets challenged, and male factor infertility, sexual dysfunction becomes a very closely guarded secret by the couple. In fact, we have seen that, which we learned gradually over time, that when there is a diagnosis of unexplained infertility, out of 4, 3 of the cases were turning out to be cases of male sexual dysfunction. And neither the wife nor the husband, they were ready to disclose it. And gradually we learned that this has to be picked up, and we learned to handle it much faster in a quicker manner. Next. Next slide.
Ma'am, it's a case too related to male factor infertility and sexual dysfunction. In the 5th year of their marriage, Mr. D, who was 36 years, and Mrs. D, 34 years, discovered that Mr. D suffered from non-obstructive azoospermia. Mr. D had a FSH of 1.01 and LH of 0.5 and very low testosterone. Mr. D was put on medical treatment with injectables, HCG, followed by menotropin injections for 5 months. Since the azoospermia persisted, he was taken up for microtessay. During this course, most meetings were with Mrs. D, and Mr. D was busy at work, and the procedures and choice was explained to her. On microtessay, no sperms were found. Mr. D went into severe depression. On further counseling session, it was found that he also suffered from erectile dysfunction off and on since first year of marriage. This worsened after a negative microtessay result.
So here, generally, the entire focus of counseling so far world over has been on the woman, because the processes are dealing with the woman, the pregnancy, the hormones, and so on. The male has been pretty much sidelined. But now it is being recognized that we have to integrate men in the treatment process right from the beginning. And if it's a dyadic relation. If the male partner is having emotional distress, it's going to reflect on their relationship. It's going to affect on the mental state of the woman also, her level of social support. And that these are the factors which
I think there is some internet issue. Ma'am, we can't hear you.
Science with the treatment. Next, Poonam.
Yes, ma'am.
Next slide. Yeah, okay. Can you give the next slide, Poonam?
Ma'am, yes, I have done it. Can you see it?
Yeah, so this is now.
Third
So
party.
here we have a closely related topic of third party reproduction. And the interesting thing is that despite the risks which are involved in reproductive success or possibility of genetic defects, the first priority is to use their own gamete rather than donors to avoid relinquishing genetic relatedness. And so continue to think about origin of the baby and whether they should tell the child about their genetic origins or not. And there's a huge debate which is still going on about how much to tell, what age to tell, if tell or not to tell. And the children who are born by this process, once they find out that this is not my biological father, what is their psychological reaction to the whole thing? It's a very interesting narrative by itself. Next. Next slide, Poonam.
Ma'am, next.
So yeah, so this is the interesting thing which I found, which is something new also, that both men and women have more negative attitude towards use of donor sperm than donor egg. And when there is a donor sperm, there is fear of marriage conflict, incomplete gestational experience, and societal opinions. So all the psychological parameters are worse when the donor sperm is used instead of a donor egg. In fact, there is an increased reluctance towards use of donor sperm compared to donor egg for both men and women, for women also. And there is a pervasive negative connotation with the use of donor sperm, which does not exist when we are using the donor egg. A mother could still love the child regardless of genetics because she carries the baby for 9 months, so the connection develops. But a father does not generate similar feelings. So this is especially in a patriarchal society where children inherit their father's name, the maternal relatedness becomes less important, and both men and women feel that the use of sperm is more likely to lead to marriage problems than the egg. Next slide. So here we had, next slide, Puna.
Done, ma'am. History of psychiatric illness.
Psychiatric illness. So for donor, use of donor gametes is something where a lot of men say that they continue to feel that this child is not mine. They use the word, this child is an alien. And that affects the welfare of the child, the family bonding. So it's a very serious issue that when there is a donor process involved, the counseling is very thorough to make sure that there is a acceptance, there is a mutual agreement about the process before going ahead for it. Then there's the pre-existing psychiatric illness, which means that already the psychological foundation is compromised, and on top of it, you have the stress of ART, possibly failed cycles, side effects of medications, and so on, the expense, that entire stress, that stress will cause a complete breakdown. And we had also a very interesting case where, next slide.
Yes, ma'am. It's
Where,
a previous history of psychiatric illness where Mr. X, 41 years, and Mrs. Y, 39 years, had a late marriage. After trying to conceive for 2 years, they came for the ART treatment. IVF was done as per the standard protocol and cycle failed. The result was negative. Husband became angry, threatening the staff with violence. And later we got to know he had a history of schizophrenia and was on medication for the same.
So in fact, we knew before only that he was on medication. He was very calm and composed right through. But when the bad news came, the wife was okay. And the healthcare team had to be told, okay, stay calm. He is going to be exaggerated in his reactions, but don't start becoming defensive or telling him, no, we did everything right. You are it's not our fault. Don't get on the defensive. Just stay calm. This is what happened. Nobody replied him back. And his wife was understanding. She says, ma'am, this is going to happen. And after a few minutes, he calmed down and he went back. So this kind of situation can potentially escalate and become negative if the healthcare team is not aware of it. And then at times we have patients who are, they say the receptionist is very irritating. The patient is very irritating. Why is he irritating? Because वो बार-बार phone कर रहे हैं, बार-बार same question पूछ रहे हैं. After every 2 hours they are asking. So then it's the healthcare team has to understand that they are in a emotionally vulnerable state. They require patience, they require kindness. And that is part of routine psychosocial care, to have that empathy, to be sensitive to the emotional nature of their illness, and to help them through the journey by being kind, by saying the right words and bearing with them. That is next, where we are talking then. Another thing that is now is the psychological screening tools. We have very simple psychological screening tools. Next slide. These have been recommended by the IFS Clinical Consensus Guideline on the basis of existing evidence. These two very powerful, very simple tools. The health question, it takes about less than 5 minutes to administer and score, can be done by any receptionist, anybody without any psychological training. And immediately we pick up that this is a high-risk case under stress. Once the score is above cutoff point, should be referred for individual interaction with the counselor to establish rapport and to find out the cause of this high stress scores. Next. Next slide. Yeah, so this is a sample. It's been tried and tested. There's all the evidence is there in the consensus guideline group as to why we zeroed in. This was both developed in the Department of Psychiatry in PGI Chandigarh and have been in use across at the national and international level since last more than 25 years. Next. Now, these are generic tools which talk about the general state. What the international bodies are now trying is there should be an infertility specific tool. Next. So we had a discussion about this, in fact. So Ashray and SRM, they have recommended 2 tools which need to be standardized and developed for Indian conditions. It's a very elaborate vertical tool, and practically we can't really use it without making the language changes and re-standardizing it. But for your awareness, maybe with the English speaking affluent or educated, it can be used. It has 2 components where we talk about the emotional reactions and the treatment vertical, how the patient feel about the treatment process, the side effect of medications and so on. Next. Next. Is a very good tool used across the world actually with various translations. And what they told in one of our discussions is that this is a very powerful predictor of further psychological distress, because the patients who are at low level of acceptance about their own infertility, they cannot accept the fact that they can live a happy life without a child-free life with other meaningful goals and significant contributions to society and to their life. So that's why we put it in green, because this has been pointed out as a as a quick indicator of subsequent significant psychological breakdown during the treatment process, and it is worth looking into. Next. So this is all, I would say again, these books are available free of cost, and it's a kind of, it offers a summary of whatever work is going on throughout the world, and it can be a good reference in the, for further work by all the new psychologists who are now coming into the field for their research and so on. It gives a kind of roadmap. Next. And we have behavioral indicators. Poonam, you can take over now.
Okay, ma'am. So in
Thank you.
behavioral indicators, there's a stress of non-fulfillment of a wish for a child has been associated with emotional sequel and feeling of worthlessness. So these are the indicators. Communication indicator, communication issue, frequent or intense conflicts related to infertility. It can be communication breakdown, can be indicative of stress and emotional strain of the relationship, or intrusive in over involvement behavior of the extended family. For instance, there are so many times, at times it happens when there is a couple but only just the wife coming with the in-laws, and even the in-laws are elaborating everything about their life, even the intimate relationship of the couple, and the husband comes only on two occasions. Either he comes on the day of semen analysis or the day of ovum pickup. And then there is differing views of the couples regarding the need for a child. Sometimes the lady is more needy than the man, and the conflict comes. Avoidance of counseling. If one person is resistant to attending joint medical sessions of counseling, medical sessions or counseling, it may suggest that they are not fully engaged addressing the infertility issue or working on the relationship. And sometimes couple comes, I still remember there was a couple who came regularly till we have done the transfer, and the result came negative, and then husband just stopped coming, and then he told, then you can go for the further cycles, and once it comes out positive, I will join back. And the lady started coming with her parents because she shifted to another place. So there was a major lack of counseling, and it was badly required in that sort of couples. Blame and guilt, when one or both partners putting fingers on each other's instead of finding a solution. So when it is written on the paper that cause of infertility is tubal or POR, so the man knows the woman is the one who, she's the reason why we cannot have a baby. So he becomes more more uh, like, I'm the right person, you are the wrong in this. And same goes with the woman, when she rules out the male factor is the cause of infertility in our scenario, so she also become that, like that. So they started blaming each other. And social isolation, when the couple accepts the fact that there is an infertility, and we cannot have a baby just because we have some biological issues with us. So they started isolating themselves so they don't have to answer about it to anyone. And such couples who isolate themselves due to infertility stress maybe experience high-end emotional distress also. So yeah, these are the behavioral indicators. Thank you. Done.
Any questions, Dr. Piki? Any questions from?
It was an excellent overview of what all things, the tools which are being used by you. And with the cases, it became very interesting and we could relate with them. I would just request you to share all these simple tools which can be used even by untrained people who are working as counselors. It will be extremely useful. And
Yes.
also, I would recommend, I've read Madam's counseling book many times, and it is a very, very nicely compiled. All the important points are there. So I would request all of you to go through it. It is freely available, as ma'am said, and we can write to her if it is required or if any clarification is required. So thank you so much, Dr. Poonam Nair and Dr. Poonam Kashyap. And now the most awaited, last but not the least, Dr. Renu Tanwar. I have introduced her in the beginning. She's a very good friend, and she's the IVF in charge in LNJP and is a passionate clinician and a teacher. So she will be talking about one very important aspect which Dr. Poonam Nair also discussed, third party reproduction, which is very new. The ART laws have changed. The emotional aspect Dr. Nair has just elaborated, and Dr. Renu will be telling us and taking us through the medical, legal, clinical point of views and a bit of emotional well-being also. So over to Dr. Renu.
Thank you so much, Piki. I'm audible, Piki?
Yes, yes. Your slides are visible. Just make it slideshow, Renu.
Yeah, I'm just doing that.
Voice is clear. You're
Okay. Thank you so much, Piki, for your kind words, and thank you for the kind invitation and to talk on third-party reproduction. I think Dr. Poonam and Dr. Rijvi have nearly covered everything. I will just go in short just to tell you about the concerns and the counseling regarding each part. So we all know that this is an important factor, and because most patients experience emotional distress during treatment, and counseling should be done by an expert having all skills that are involved in professional counseling. A counselor should consider all aspects of couple, including the emotional, the physical, the social and psychological aspects. And counseling should help in decision-making process for the couple. That's very important, that the counseling should be done in such way, because these patients are running from pillar to post and they are really in dilemma what to do, what not to do. So that kind of counseling, that they come to a decision, that is very important. And we know that counselor roles has evolved due to many considerations. Now the practice has become different. There are laws which are coming up, and one more thing, that because of ethical guidelines, all that has become very important. And even there's an access to the internet. So all the patients, they are all well read, and they have many things, doubts which should be cleared by the counselor. Now, third party, we all know. What do you mean by third party? This is an arrangement where a person or couple seeks help from others to become a parent. That is what it has. It has three people involved. That is known third party reproduction. And it can be in the form of a donated egg. Maybe just egg has been taken. Maybe a sperm has been taken. Or maybe the uterus has been taken for care. Maybe a surrogate woman is required to carry the pregnancy. Or it can be a combination of all these. So there's extreme degree of complexity when it comes to ethics, relationship and legality that should be kept in mind. And all this affects the mental health and quality of life of a couple, because they are trying to take a genetic material from somebody else. And that is why their mental health, and there's so many concerns regarding this. And whenever we talk of third party reproduction, I think that there's the detailed screening of the person, or everything should be very good. Counseling should be from a mental health professional, and there should be a better collaboration between the clinician and with the mental health professional. Now, the concern regarding to the third party reproduction is the psychological concern, then the consanguinity. Then the informed consent is very important. Whatever we are doing, whatever has to be told, the informed consent should be there. I'm giving 1 minute to this because this is very important. Though we may be telling so many things, but if you don't take the consent, things may go wrong in third party reproduction. The patient, anytime the husband may say that this was not told to me, even the lady can say that this was not told to me. So informed consent, the language which they understand, is very important. That has to be told. The risk disclosures, the compensation for donor and child welfare has to be taken into account. Now, indications where we want to do oocyte, ask for the oocyte donation is that in patients with premature ovarian failure, they have a very low ovarian reserve and maybe they have multiple failed in vitro cycles. That is where oocyte donation will be required. Sperm donation mostly in cases of non-obstructed azoospermia, because in obstructed azoospermia, you may get the sperms of the husband. That is why. And presence of any heritable genetic disease where we want that the couple doesn't want that to carry on in the family, and they may opt for a sperm donation. Surrogacy, if there is a Asherman syndrome in the uterus, there is a lot of adhesions and either the cavity, the lining doesn't make out any time. So definitely we have to tell them that you need a surrogate to carry out the pregnancy. There could be absence of the uterus, and there could be any Mullerian anomaly, and even in cases of recurrent implantation failure. Psychological concerns. Now, I have divided all this into different parts. So, oocyte donation I will be taking first. What are the concerns of the recipient and what are the concerns of the donor, and what counseling is required for the recipient as well as the donor? So, the concerns for the recipient is fear of revealing that it is a donor conceived child, and claim of the child property issues could be there. Anytime they may claim the child is theirs. Then the recipient is also because of the genetic diseases may be running, maybe she does, which they don't know that the donor was having, and then she takes it, that the egg donor has been taken it. Then their expectation in terms of appearance, she may say what kind of the child will look like, she doesn't have the traits of mine. So all that is there going in her mind, and that has to be told to the patient. Guilt of not being able to have her own genetic child and disrupts her mutual harmony between the couple. So that kind of fighting is also there, when that my genetic material has not gone, so this child doesn't belong to me. So all that kind of fears are there, the concerns are there, and maybe she thinks that she's not able to, this is a social obligation of bearing a child and she's not able to do it. So counseling for the recipient is that she should be told that you accept the process with gratitude, feel contented about the genetic traits at least of one of the parents. So oocyte donor has been taken, but then she should be at least the sperms are of your husband. So that kind of feeling you have to tell the patient. You have to be told that they have to be told that you have be happy and appreciated to experience the motherhood. Though the genetic material, the oocyte is not there, but then she can carry the pregnancy forward. So that kind of counseling will help the patient to come to terms whenever they take for the oocyte donation. So donor, what are the concerns of the donor? Concerns of upbringing. Though she has given the genetic material, she's given her oocyte, but then she also keeps on thinking about the upbringing, the nurturing, and the emotional bonding she might have with the child. And she may think that she may want to meet the donor conceived offspring, maybe in a time, and also the risk of OHS to the donor at times can happen because we are stimulating the donor. So maybe that risk is always there to the donor. So that kind of concerns have to be talked about, and they have to be told that everything has to be explained to them. So detailed explanation of the procedure, everything has to be told. Even if this many eggs have, you have to counsel that you will be taken care of, you will be admitted, nothing will go, we'll try our best to do everything. So that kind of thing has to, otherwise it is very difficult to, if you don't counsel these donors, nobody will be ready. And then she should be told that you will have no rights over the child born. That thing has to be applied from the starting, so that suddenly she doesn't think everything, this child is mine. Maybe if it is a male child, if the male child is born, then I will take the claim. So all that things keep on going inside the mind of the donors. So that has to be told regarding the counseling part. Regarding the sperm donor, yes, the males, I do agree. There was a talk that males definitely have a lot of this thing when they are not able to, they don't have their own sperm. So they have a thinking that they are not genetic linked to the baby. Their lack of sense of security about the child's claim. There's challenge to a man's ego and his very existence that he's unable to father a child. That kind of concerns are there in the husband when he takes the sperm, when the sperm donation has been taken off. So counseling should be help in the decision-making process, discussion on the consequences of openness and secrecy of the procedure to the society or the child. You should be told, everything should be told to the husband and this thing, that everything will be told, whatever is happening, the number of embryos formed, and that has to be told. And the role of informed consent is very vital, which I told you. And that involves all the parties which are taking part in this third party reproduction. Surrogacy, I just told you, that is the lady offers her uterus for carrying the pregnancy. She will carry the baby forward. Now, the concern for the recipient is she has a constant regret and grief for not able to experience the pregnancy. That is the concern. That is the concern of the lady over there. She may have given her oocytes, but yes, she's not able to carry the pregnancy. Fear of optimal health and hygiene of the surrogate. Even that keeps on coming to whether she's remaining healthy, what is the hygiene, will she take care of the baby inside, will she eat properly? So all that kind of things are there. Fearfulness of the surrogate claiming the child, and she also has that maybe one day she may claim the child. All that keeps on, even if you have taken, but these thoughts are coming to the patient. These thoughts have to be taken care of, and complex connections and relationships, that's very important. Regarding the concerns of the surrogate, what are the concerns of the mental and physical health of the surrogate in the antenatal and postnatal period? Fear of multiple pregnancies. She may think that I may be having, I don't know, one has been put or two has been put, though the consent is there, but one can divide and say, even if you put one embryo at time, the division can take place. So that kind of concern is there. She may think that the couple may abandon the child owing to any congenital anomalies may come, that they may abandon, then who is going to take care of the child? Stress related to the social stigma, and no monetary compensation is given in India. They are only insured. So all that kind of thing has to be told to the surrogate as well. Counseling is that sessions, you have to take sessions with the intended parents separately. Then you have to take a session with the surrogate. Then there should be a joint session with both the intended parents and the justice, so that everything is clear in front of everybody. It's not just you're talking something to the couple, you're talking to something to the justice, and simultaneously everything should be clear cut and it should be transparent. So there should be a motivation for the surrogate to do that. Welfare of the existing children of the commissioned couple or surrogate, informed consent. I just told you there should be boundaries of the surrogate, the difficulties that arise from using gamete in surrogacy and handing over the child and bonding, all that has to be taken care of. The counselor must have a detailed knowledge of all the issues in surrogacy and the legality involved. So that's very important. The laws which are there, that has to be known by the counselor. Otherwise, everything can go wrong. So that kind of the legal part is very important. There should be a thorough discussion on the complications of pregnancy, including miscarriage and reassurance of the treatment. So that can also be told. It's not that once the embryos have gone, it will take the pregnancy to term. She can have just like a normal pregnancy and abortion. She can go into preterm. All that length has to be told to the patient, all the surrogate mother and to the couple. Now, one or two lines about the absent uterus. Yes, this can also be there. So I have also talked about some special situations. Piki had told me to take a few special situations where counseling is required. So that means we do see some patients with MRKH syndrome where there's congenital absence of the uterus. Or there could be like she has maybe she had born the child, but then she landed with hysterectomy. Now she wants a child. She doesn't have a uterus. Maybe all that kind of thing could also be there. And she doesn't have any living children. So even at that time, that can be taken out. So congenital absence of the uterus, you have to tell the patient that's a rare disorder. She will definitely need psychological support, counseling, and patient education. You have to tell her the options what are available to her. So obviously, if there's no uterus, she will require IVF and surrogacy. And if she does not want to undergo IVF, she doesn't have the money to undergo for IVF, maybe then adoption is the option for them. And prognosis is good after surrogacy. So counseling for these patients with absent uterus is an ongoing process. They need support throughout their journey, and offer a follow-up appointment to assess their progress and questions, whatever they have in doubt. So all this is a concern: ability to conceive and carry a child, low body image and self-esteem, sexual health and intimacy. Actually, at times they don't have the vagina. Even there is the vaginal agenesis there where you have to create a new vagina. So even that kind of problem is there, which has to be taken care of, and they need treatment. So this is a multidisciplinary team which involves the gynecologist, the psychologist, the social workers, and fertility specialists. You have to establish a better environment, and you have to give them the right information. What will happen if then what about the sexual health? That has to be told to the patient. You have to encourage the patient to embrace uniqueness and focus on the strength and abilities beyond reproduction. You have to tell maybe, okay, this is wrong with you. Maybe the uterus is not there, but then you have to tell what are the other strength. You have to tell her that maybe a surrogate will be helpful. Then she will just focus on the strength and other abilities. So that could be maybe a peer support group. You have to tell them where she can connect with these people who are having the similar challenges, so that she doesn't feel alone, that she's alone in this world with all these problems. You can tell her that many people, and that kind of support is there, then they all feel connected together. That's very important. And you have to encourage the self-acceptance and self-care and self-love to the patient. Emotional support, I told you, counseling either individually or in groups, all that has been taken care. And just we'll see about the sexual health and maybe vaginal dilatation, lubrication, sexual position, or an open communication, all has to be taken care for these patients. Regarding premature ovarian failure, yes, Dr. Poonam has just taken. I think these are the patients who will require IVF and donor oocytes. And prognosis, if it's a poor prognosis patient, at times the patients, it's a poor responder, maybe at times they will be difficult. But yes, with donor oocytes, these patients can conceive and have the joy of a motherhood. Concerns regarding POI, I told you they are also very, these kind of patients, they have a psychological distress of infertility, which causes emotional distress. They have a reduced life expectancy as compared to those patients who have a normal age of menopause. They have increased risk of cardiovascular events. So all these concerns should be taken care of. All these, it's not only that bearing a child, but yes, risk of cardiovascular events, poor bone health, long-term follow-up. They will require HRT, that has to be told. They have to be told about the sexual function. They may have repeated urinary infections and all that. That has to be taken care of. Neurological function, all these are concerns of premature ovarian insufficiency. And definitely the quality of life. They think they will age earlier than their counterparts. So they have a sense of helplessness, and that is why that's very important. So I told you, there's again, in cases of PI, it's all a multidisciplinary team now. We just don't want that only we will be dealing. Yes, she requires an endocrinologist, a psychologist, donor oocytes, and I've covered all this in my previous slide. So that's there. Then regarding PCO, this is also one of the important things which has to be taken care of. You know, these patients will require ovulation induction because at times they have their issues of obesity and infertility that has to be taken care. But yes, you can counsel them that ovulation induction with oral drugs and they can get pregnant. Regarding their concerns, that is about the acne, the hirsutism, the obesity, that has to be taken care of. You have to, at times they have a negative body image, they feel inadequate, unwanted, and dissatisfied. So that all has to be taken. Counsel them in such a way that they feel that this is not so thing. They can reduce their weight, they can maybe go for some intermittent fasting. All that help should be taken care, and they should be told that they should high risk of metabolic syndrome and endometrial hyperplasia. So they have to keep coming to the gynecologist and keep getting their examination done. Their lipid profile has to be taken care. So I told you that all that has to be done for these patients. The counseling, we don't have to judge them. We don't have to scare them. We don't have to shame the patient. We have to tell them to help to build their self-esteem. That is very important. And there are different scales which are there. And I think Dr. Poonam was talking about to assess the quality of life. So PCO also patients, because of this obesity and all that, they do require counseling. So this all has been taken care of. If I just told that lifestyle modification, the first part that has to be told about the exercise, the diet, and then treatment options should be explained. And they should be told that you will have a desired clinical outcome. And then that is how the patient can become satisfied. You should encourage the patient with always a positive attitude. Never tell them this is wrong with you. Tell them what you can do and help them out. Now, this is all the psychological support, which I just told you. This is just a diagrammatic representation that it requires all these kind of things, cosmetic, lifestyle modification, fertility treatment, all that has to be told to the patient. This is again for the adult woman with PCO. There are different approaches, and this all tells about the different psych and everything has to be taken care of. Now, cases, just few lines about the male and female sexual dysfunction. Yes, at times this is the primary cause of infertility. There's impairment or disturbance in one or more phases of the sexual response cycle. That is the desire, the arousal, the orgasm, and the satisfaction. That has to be taken care. This is what we mean by the sexual dysfunction. And definitely this itself could be a cause of infertility. Couple may also experience sense of failure. They have low esteem and self-confidence. So what is the counseling that has to be taken care is that sexual history interview. You have to tell them about the active coping style, a positive reinterpretation of infertility, sex education has to be told, and basic behavioral techniques and cognitive behavioral techniques are very important in cases of female sexual dysfunction, which Dr. Poonam has also covered. So we have to, maybe they have something like dyspareunia, pain, erectile dysfunction, maybe organism dysfunction, premature. So what kind of problem they are having, you have to counsel the patient and accordingly treat the patient and counsel the patient that this all can be treated at times, maybe some drugs, maybe some cognitive behavioral therapy also. So in last, ma'am was talking about this clinical consent guideline. I do recommend all of you to go through that. It will definitely help in counseling the patient. So these are some of the recommendations from that book only. And I just request everybody to go through that. This is all the repetition which have all talked to you regarding all this. And definitely this was about the sexual disturbances. So all that grading is there. You please go through this book. They are very well written. And even I have gone through the madam's book. It is well written. Thank you so much for your patient hearing.
Okay. Thank you so much, Dr. Renu. I think that was a very, very good overview of what all emotional, medical, legal aspects are there, which need to be considered on the part of the clinician, the counselor, and the patients and the donor. So you have covered it beautifully, and I thank you for this very nice presentation.
Thank you so much, Vicky.
With this, we are coming to an end, and our mentor, Dr. Geeta, had to leave due to some family emergency. So I thank all the speakers today. It was indeed a wonderful program, and all the people who are attending. Because of you, this program is such a successful program. And if there is any question or any comment by any of the viewers, you are most welcome.
I think there's nothing in the chat box. I was just seeing that.
Yeah.
I
So
think
thank you so much, all of you.
thank you so much. Thank you, Piki. Thank you so much.
Thank you. And we take your leave. Dr. Rajvi, would you like to say anything?
No,
Last
no. It
words?
was very nice to see all the different
It was a
aspects.
wonderful session by Team 5. And
Yeah.
I think it's time to say goodbye and see you
Bye-bye.
again for the 6th session soon to be held in October. Thank you very
Thank
much.
you.
Thank you
Bye-bye.
so much. Thank you, Piki. Bye, Rajvi.
Bye-bye.
Thank you so much.
Bye. Bye-bye.
Bye.